Thank you, sir. Good morning. So, thank you for joining us in the early morning. So, the title of my presentation is Back to Basics in Uveitis Workup and its Relevance in Modern Diagnostic Armamentarium. So, I will be highlighting the role of naming and meshing in a uveitis case workup. So, the main aim of a primary or specialist eye care physician when he deals with a case of uveitis is to establish the proper diagnosis and to start the treatment according to the etiology. So as far as if we go back into the 80s also, there is this chapter in one of the books which highlights that most of the diagnosis can be made on the basis of clinical history and examination. Yet there is a strong tendency of the physicians to rely heavily on ancillary testing. So these the coming slides will highlight how history and examination only can help us in reaching the diagnosis. So the basic uveitis workup consists of history, the review of systems, ocular and systemic examination, and the techniques of naming and meshing. And the ancillary testing has to be done according to the information which we get from the first 5. So why is it necessary to do naming and meshing in a case of uveitis? So uveitis can have numerous disease association and varied etiologies. It can be infectious, non-infectious, immune-mediated. Also, different entities can have similar signs and symptoms. So it's very important to differentiate these. It can present only limited to the eye or can have systemic involvement. So these things make the diagnosis challenging. As far as problem solving in uveitis is concerned, as previously highlighted, differentiating the etiology of uveitis is important, which can be done on the basis of ocular history, systemic examination, and looking into the disease course. Also, it's very important to pay attention to review of systems and have a good ocular examination. It's pertinent to have to classify the intraocular inflammation to the different chambers of the eye, and then with the help of laboratory and imaging, we have to reach to a diagnosis. So how exactly is naming and meshing defined? So in order to define a problem, which is uveitis in our case, we have to define the problem first and then derive at a clinical diagnosis. As far as meshing is concerned, it is review of all the possible causes of the condition and then comparing it with the known uveitic patterns. So this is the how we should go about naming the disease. So we have to pay attention to the age, as certain diseases can be present in a certain age. Then pay attention to race, the gender of the patient, what is the severity of the disease, what is the chronicity, whether the disease is unilateral or bilateral, whether the pathology is granulomatous or non-granulomatous. Then look into the location and what is the pattern of uveitis associated with ocular and systemic findings. So if we go in this step ladder pattern in naming, we can just describe the disease first. So let's move on. This is the slide which shows that how certain diseases can present in a certain age. JIA is more common in children. Parasitic uveitis is also common in children. HZO is mostly a disease of the old age. Again, certain diseases have a gender predilection, like VKH is commonly seen in females, autoimmune diseases is seen in females. However, sympathetic ophthalmia is more common in males. Again, race, sarcoid is more present, is common in the pigmented races, Behçet's in people residing in the Mediterranean region, and ankylosing spondylitis is more common in Caucasians. A socioeconomic status can also influence the uveitis presentation, as people with poor socioeconomic status may have trematode granulomas. More common, the parasitic uveitis can be common in these subgroup of the population. Also, ocular symptoms themselves can help us in localizing the disease, as although this is not absolute, but pain and redness is more commonly seen in anterior uveitis, floaters in intermediate uveitis, and as retina and choroid is involved in posterior uveitis, decreased vision can be the initial symptoms of the patients. It is important to pay attention to the chronicity of the diseases. Some diseases can present as with the acute course, however other can have a chronic and persistent as well as recurrent course. It is pertinent to pay attention to the pathology, whether the disease is non-granulomatous or granulomatous, and what is the etiology, whether it is infectious, non-infectious, there has been trauma, or we are dealing with a masquerade. Classification is very important. So as we are examining the patients, we have to see whether the disease is localized to one part of the eye, whether the anterior chamber is mostly involved, whether it is an intermediate kind of disease, or primarily chorioretinitis or retinitis is there, which is a predictor of the posterior disease. If all the chambers are involved, then we will label the disease as pan-uveitis. So why classification is important? The classification is important because it will help us to, it is just like indexing or how we visit a library. It will be easy to find out the disease if we have done proper naming and meshing for the disease. So these are the examples how we are, if we apply this step ladder pattern, how we can just narrow down our diagnosis. So if we can see the first example, a 9-year-old white girl with moderately severe acute bilateral non-granulomatous of type of iridocyclitis with mild, if we pay attention to the this finding also, which are the ocular and systemic findings are coming in, the bilateral band-shaped keratopathy in the eye, and occasional right knee pain or joint involvement. So we can narrow down our diagnosis to juvenile rheumatoid arthritis. Similarly, if a black woman presents with severe chronic bilateral granulomatous diffuse uveitis, which is associated with painless vision loss, and then is associated with lacrimal gland enlargement and retinal periphlebitis, then we can again, just from the history, examination and systemic examination, we can narrow down most of our diagnosis. So meshing is basically a clinical picture which has been a synoptic description which we have come to a conclusion from the initial part of our workup, that is naming. Then we compare it to the other common uveitic entities and again come to a limited diagnosis. Coming to this slide, it is important to pay attention to the anatomic location, typical findings which are seen in typical diseases. Like conjunctival granulomas are commonly seen in cases of sarcoidosis and foreign body. Again, we will be moving on to the next slide. So these are two cases which are presenting as a hypopyon uveitis. So they look similar. How we can just differentiate between the two entities? This is the first patient, who is a 23-year-old male presenting with severe persistent bilateral non-granulomatous anterior uveitis. So if you can see on the right side of the slide, so this is the typical pattern which we have to follow, and if we follow this pattern, most of the diagnosis can be made with the help of a naming and meshing technique. So as this was associated with, if we can see the morning stiffness, which is typical of HLA-B27 disease, and similarly in this patient, the clinical sign was that there was presence of a shifting hypopyon, and the patient had ocular and genital ulcers. So we narrowed down our diagnosis to Behçet's in this case. Thank you so much.